Hoje nós temos o privilégio de ter entre nós dois expoentes da cardiologia intervencionista dos Estados Unidos, Dr. Ajay Kirtani, que comanda o laboratório de cateterismo da Columbia University em Nova York, e o Dr. Gagan Singh, que comanda o laboratório de Sacramento, US Davis in California. So welcome, and we have a very relaxed discussion today about complex intervention. Ajay, I think you were one of the pioneers in this new nomenclature called SHIP. What does it mean and why is it for?
Well, I'm not a pioneer. I was fortunate to be in a good place with good mentors, and I still remember it was in Jeff Moses' office with Jeff, Marty, and we were basically just talking about this need to treat patients with more severe disease, because I think that as we get on our training, what we start noticing is that it's okay to treat patients that have less severe disease, but many people can treat those patients. What we really want to be able to focus on is, can we treat the patient with the most complex disease? And so this term, complex, higher risk, and indicated procedures or patients, it tries to focus on those patients that have a lot to gain. They have a lot of symptoms, they have a lot of disease. How can we be better equipped to treat them with techniques, tools, and beyond to do it safely to make them feel better?
Is there any study that tells you that there is a clinical impact of having a better planning for this, identifying these patients first, and sit down with the team and say, I'm going to use an ablation in this patient, I'm going to use a shock wave, and so on, to make sure that you have a better clinical impact?
It's a great question. Actually, I don't personally know of specific studies that have studied that approach versus the more conventional approach, but what I can tell you is that most of the studies looking these days at the treatment of complex patients have employed some sort of planning element, heart team element. It really started with the Syntax trial, but beyond that, even the valve studies, et cetera, they really implement this team-based approach. And I think that's what many of us have tried to emulate when we work in clinical practice with our surgical colleagues, with our non-invasive colleagues, EP, heart failure, et cetera, to try to make these decisions, because it's not so easy to do it just by yourself.
Wonderful. Gagan, you come from a very busy lab. Do you think that it's appropriate in the near future, or even today, to have doctors trained in specific procedures? For instance, if you go to your lab, do you have a CTO person who only deals, or most of the time, with complex CTO patients, as opposed to a person probably that is an expert on bifurcation?
Yeah.
Do you think this is the future, to have more dedicated interventionalists for different anatomical situations?
Yeah, I mean, I think, what's interesting is that the more you do of something, the better you get at it. And I think that adage applies to not just coronary intervention, structural, and in our daily practices, and even outside of our professional lives. And so it's really important that you pick one part and you become really, really good at it. And especially when you talk about things like CTO, especially when you talk about things like left main. So as you're going through training, you're going to get exposure to everything. And then what happens is, for 3 years, 2 years, whatever, during your training, you've done everything, and every day you show up, there's 30 cases to do, and then you end up in private practice, and then you're doing 1 case a week, and you're like, whoa, wait a minute. So it's very important that when you first finish, you're going to have this wealth of knowledge. Try to surround yourself with mentors, and do your first set of cases with your mentors. And it'll take some time until you develop that niche, whatever you're going to be. And it could take months, could take a few years, but it's very important that when you first start off, you work with your mentors and you do these tough cases together, and take that CTO specialist, take that bifurcation specialist, and do those cases in combination. That's how you grow, and that's how you always have positive outcomes.
I think this is a great advice for our fellows and future trainees. I think one very important question that we've been talking about for many years is the heart team approach. So for perhaps 20 years ago, when we started to treat left main disease, we talked about meeting with our surgeons, our clinicians, our imagers, but this kind of fade away a little bit, and the revive of the heart team came with TAVR, right? So in your hospitals, how often do you meet to make decisions? You have the extremes, for instance, in a TAVR patient that is very simple, that is straightforward, that perhaps you don't bring this patient to the heart team discussion. The same with coronary disease. A single mid-RCA, very simple to treat, that it's a no-brainer, right? And on the opposite, you have perhaps a multivessel disease patient, but high risk for surgery, even if the patient is diabetic. When do you bring those patients, your patients, to a heart team discussion?
Well, for me, we don't actually have formalized heart team meetings because we have a lot of different operators and different surgeons. But what I would say is these conversations are essential. And the times we bring them forward is when you look clinically and there seems to be multiple ways to treat the patient. Sometimes patients actually don't like it. They say, why, that's just easier to put a stent in. Why don't you just do that? And the reason is that, you don't want to necessarily do that if there's another therapy that might have better long-term outcomes, even if they ultimately choose doing PCI. So my feeling is that you don't have to be formalized meetings, but back to the point about the operators, there's a really interesting study from the largest cath lab in the world, Fuwai Hospital in China. And in that hospital, in the same hospital, operators that treated more left mains versus less left mains in the same hospital, much better outcomes, mortality advantage to those that did higher volume. So always involve other team members in the decision making, and I think that'll help the patients.
Yeah, I would just add that in the digital world, the heart team has kind of morphed into this thing that you can't really tell what it is anymore. Pre-COVID, pre-Zoom, WebEx, there was a standing weekly meeting several times. And in cardiology, we'll give you a meeting every day of the week, I promise. We have that at our institution as well. So there's always ways to catch a surgeon, catch the imager, catch the primary cardiologist, and then kind of make a collective decision either offline, or we do have formal meetings where we bring cases together, and they can be something as simple as a mid-right if you want to, if you have the time, to more complex valve disease. But the key is communication. And if you break down in communications with your surgeons and your referring doctors and the patient, everyone suffers. So that's kind of going to be the key thing. And every local politics are local politics. Some places it's going to be easy to have a daily meeting where everybody gets together. Most places, Colombia, California, Brazil, everybody's all over the place. It's going to be hard for you to get all members of the heart team in one room for 1 hour continuously. It's going to be very challenging.
Yeah, but we have to be smart to select the patients that will benefit from this kind of discussions, right?
Absolutely.
So finally, I want to touch bases on something that Ajay recently brought up, which is the patient-centered decision, as opposed to hospital or physicians, right? So being less selfish, Ajay, what's your advice to treat a patient in terms of identifying what the need that the patient has and what kind of procedure and where and when?
Yeah, that's the huge question. And the reality is that in American medical schools, they often teach you as physicians, present the information to the patient and let the patient make the decision. The reality is many patients have no way of comprehending the information you give them. So I think the part of being a good physician is trying to understand where the patient's coming from, where their family's coming from, how to allow them to process the information in that way. You could present the exact same information to a patient and they can choose two diametrically opposed treatment plans just based on how you present it. So the key is involve them, try to get an idea of what they value, what's important to them, what they can do. So somebody may have multivessel disease, but if they're the only caregiver for their family member, it won't matter. They can't take 6 weeks off to have a bypass surgery. So those patients you may favor doing a high-risk PCI, but then do it with the right person to do the case. So that type of decision-making comes with every single patient that we see.
Yeah. Gagan, you are very privileged because you come from a center that have the best experts on mitral, on aortic valve and coronary, complex coronary. So it's not the scenario that you see most of the centers in the US. So how you deal with patients that are referred to you in terms of management?
Yeah, I think the what's interesting is that, and we were just talking about this recently, Tony DeMaria was one of the former editors for JACC. He said that if you take two groups of patients, one is that, so left main intervention, for example, if the patient meets all the inclusion-exclusion criteria, their survival curve is very different than a patient who doesn't meet the inclusion-exclusion criteria for a particular left main trial. The patients that we take care of on a daily practice, on a day-in, day-out basis, most of the time do not fit the context of a clinical trial. So how do you approach them? And even at a center like such as ours or Columbia, elsewhere, is you have to walk in with whatever is the best decision for the patient, what is the best, taking into account what is their best outcome. And I agree with Ajay, sometimes you give the patients an option, they're like, well, doc, what would you recommend? And you're like, well, we're back to square one.
That's right.
And so you always do what's in the best interest of the patient and the best interest of the family And as long as you take that approach, families will always listen to what you have to say.
And medicine is hard sometimes. You remember your last bad case, and so somebody had a bad outcome with surgery, and then you sort of feel viscerally, I shouldn't send the patient to surgery. But it's okay for it to be hard. That's the beauty of it. Whenever you struggle with something, then when you make a success, you feel better about it in the end.
So listen, this was a great discussion. Thank you so much for being here in São Paulo at InCor to allow us to interact, not only learn more from you, but also to do cases together. Muito obrigado pela audiência, mais uma conversa muito interessante aqui do TripleI. Obrigado por nos seguir e nós teremos muito mais conteúdos para vocês no futuro. Obrigado.